Good morning, good afternoon, everybody. We're very pleased to be with you, although unfortunately not in person, but look forward to a lively discussion as we hope. COVID-19 has been the ultimate stress test for our pandemic preparedness and has exposed gaps across international and national levels and systems. But COVID-19 also has the potential to leave a legacy that will enable us to be better prepared next time, because there will be a next time. New forms of collaboration and strengthened partnerships have emerged as central to the response. Building back better means future-proofing the healthcare ecosystem through partnership and across systems and commodities. When we work together, we can achieve great progress. One such example is the ACT Accelerator, a global collaboration to ensure equitable access to all the tests, treatments, and vaccines that we need to defeat the pandemic. Major milestones in this partnership were achieved with unprecedented speed. As many of you may have heard, 171 countries engaged in COVAX, with delivery of up to 200 million doses of vaccines secured. Dexamethasone has been secured for up to 2.9 million people in low-income countries. Affordable quality antigen RDTs, rapid diagnostic tests, ready for rollout within 8 months compared to, for example, 5 years for HIV, with volume guarantees for 120 million tests in 133 low-middle income countries have also been secured. This progress in the diagnostic field is enabled by many donors that believe in multilateral partnership and solidarity. Here's a brief video to hear why donors are so committed to pandemic preparedness. Thank you. May I ask the organizers to start a brief video?
Safe, effective and affordable diagnostic tests should be available to everyone, whether you're on a distant Pacific atoll or in the heart of a busy metropolis. To help end this pandemic, FIND is working to make sure that no one is left without access to high-quality tests.
We have all experienced the detrimental effects of COVID-19 on all our countries and at all levels. We in the Kingdom of Saudi Arabia and during our presidency of the G20 have ensured that our greatest attention is given to combating this disease collectively. During the G20 Finance and Health Ministers meeting, we emphasized the importance of a global response in order to accelerate research and development of diagnostics, therapeutics, and vaccines through the ACT Accelerator and with the support of the WHO to ensure equitable and affordable access to all. We rely on world-leading organizations to make this happen, one of which is FIND, an organization that is devoted to the development and delivery of innovative diagnostics globally. It is by solidarity and partnership with leading organizations such as FIND that we will be able to combat this pandemic together.
Testing the right people at the right time and with appropriate tests is essential to control COVID-19. The ACT Accelerator is demonstrating the power of global solidarity and multilateral collaboration. Switzerland is proud to support FIND as a Swiss-based organization. 120 million rapid tests have already been secured for low and middle-income countries, but much more is needed to bring the COVID-19 pandemic under control across the world.
We are seeing health systems and health workers stretched to their limits, with frontline carers putting themselves at great risk every single day. FIND's work in this crisis is key to keeping the global health workforce, mostly women, safe.
Until a vaccine is widely available, we must work together to ensure that everyone can access frequent, rapid COVID-19 tests. This is the only way to contain this pandemic. The Rockefeller Foundation's $10 million commitment to find and the ACT Accelerator will support the ambitious yet achievable goal of enabling equitable access to COVID-19 diagnostics for everyone.
No single country, no single organization, and no single vaccine or test can defeat COVID-19. We must work together to fill vital gaps across the whole healthcare system, including the urgent acceleration of diagnostic innovation and scale-up of quality tests.
Thank you so much. On this note, it's my pleasure to welcome here 4 great speakers and panelists in our session. After they have spoken, we will have a question and answer session with the audience, so please submit your questions in the chat. First, Christian Drosten is an internationally renowned virologist. I'm sure everybody in the audience knows him. Currently director of the Institute of Virology of the Charité Universitätsmedizin Berlin. Germany has been a champion in fighting this pandemic and in controlling it. And Christian Drosten has been at the forefront along the way. I also am particularly happy to have Christian with us as he's a fellow diagnostician. Christian, welcome to the stage, and we're glad to hear your thoughts and your experience and perspective on this subject.
Yes, thank you for having me. So I will not give a very political talk, but more give 2 examples about current issues in diagnostics. One is how we rather quickly introduced the diagnostics in Germany, and obviously how this was then used also to provide a foundation for diagnostics internationally, and then some data on antigen tests, on rapid antigen tests. This is a timeline here, starting end of January 2019, end of December, and showing that at this point on 10th and 11th of January, we had first genome information published. 2 days later, we had a first version of our test protocol, PCR protocol, up on the WHO web resource. So we were this fast because we could rely on our knowledge on SARS-related coronaviruses sampled from nature, basically from bats, from years of ecological study, from both Chinese colleagues as well as our lab in Europe and several others working on this issue. So we could make an assumption of appropriate assay design to detect this new virus just based on the information that we are looking at a SARS-related coronavirus. This is a virus species, and there is a certain degree of relatedness among all the members of this species. We had an updated protocol version up on the WHO homepage on 16th of January. And during this time, these few days and then onward here to the day of publication of a full paper on the assay, we did a clinical validation using clinical samples from patients infected with other respiratory agents to make this protocol a very safe protocol. So we could be sure that what we roll out is in fact ready to go and will not provide errors in detection. So this shows a map of Germany beginning of March, and it shows a situation that is quite typical for the incursion of the pandemic into a European country. These are imported cases detected quite early on in Germany. And this is the special case in Germany. If you look at March, what you can see is, and this is the testing capacity, that the German testing capacity was up to 300,000 per week already in March. And here we have the positivity rate. This is the peak of the first wave in Germany. So well ahead of the first peak of the first wave, we had this rolled out through the academic system in private and academic labs mainly, in a system where there are no real restrictions, no regulations prohibiting the application of diagnostic tests or making this a central issue, but where we have actually a free academic system and a free market as well. And where we, this way, by rolling out the information and the positive control material through the academic collaboration, we're able to detect our third case in Germany as an autochthonous case. So the first two cases were directly imported from Southern Europe, both of them linked to each other. Case number 3 had no travel connection. So this, of course, created a situation where politicians in Germany had two impressions. One was the general notion of a severe disease. The other, the notification that the disease is already present in the country and is not anymore just imported. And this, of course, triggered the decision for an early lockdown in Germany that has paid off until this day. So we have here our peak of incidents, the ban of large gatherings, the school closure, and the general distancing rule. This was stretched over a period of 3 weeks, and up to well into September. So these measures were lifted about here, but well into September, the incidence stayed very low, and we assume that actually the reason for this low incidence is that we imposed a lockdown very early on. So a really successful example of academic collaboration. So as in many other European countries, our public health agencies are now beginning to lose track of cases as we enter into the second wave of incidents. We consider an emergency mode based on retrospective cluster tracing, but this is not really completely worked out. We also consider an introduction of a testing for infectivity rather than infection based on PCR using a viral load criterion. These are two major developments now that are in discussion in Germany that may help to modify the public health response hopefully very soon. I'm not going to address these issues. What I'm going to address now is antigen tests. There are some new preliminary data. Many people are interested in the performance of these tests, but the rationale here, and I would really like to introduce this first, is we have here a probability density curve of transmissions. These are transmissions based on real epidemiological observations based on this paper. And we have a whole row of clinical virology studies that correlate the time after onset of symptoms with the isolation rate of infectious virus. So this is the first week, day 0 is day of symptoms, first week, and we see that by the end of the first week, actually in most patients, transmission is over. And we can say that this end of first week, the point at the end of first week is a point that's marked by a virus isolation success in cell culture of about 20% based on several studies that all agree on this notion. So as we reach a point where we can isolate about 20% successfully in terms of cell culture inoculations, this is the typical point of stop of infectivity. And the interesting thing is we can make a correlation based on the virus concentration in a tested sample. And then from the same sample, the rate of positive virus isolations in cell culture. And we can come up with a data point saying that this 20% success rate, this is reached between 10 to the 6th and 10 to the 7th copies per milliliter. So that's actually a viral load, which we can remember while now considering antigen tests. And we've just concluded a study on 7 products, so 7 different products, antigen tests that are now entering the market or are already in the market. You see the number of clinical samples tested to evaluate these tests, and these are stored swabs that were previously quantified by RT-PCR, by quantitative PCR. And what we can say, and this is the most 5% positive point for these antigen tests. And you see these antigen tests, they have their limit of detection around 10 to the 7th copies. So this is just only slightly above this point of end of infection. This is the most important notion that I have for you in this talk. There is even, I should say this, there is a slight dilution factor here. So the real sensitivity is even slightly better for these antigen tests. So we could develop the working hypothesis for public health that a negative result in an antigen test predicts the waning off of infectivity in the tested patient. Another issue is the specificity. So how specific are these tests? First issue that comes up obviously is what if we have another coronavirus in the sample? So these are cell culture materials of all the endemic human coronaviruses, quite a high virus concentration. You see with this one exception, which is a technical exception, there is no cross-reactivity for any of these products, any of these antigen tests. However, there is another issue of specificity, which is when you switch to testing clinical samples. So these are assays 1 through 7, and these are pathogens contained in this number of clinical samples. So we have a reference panel here of clinical samples from patients diagnosed previously and well, then typed and quantified for viruses that typically cause common colds. So these are the leading pathogens in the samples. And you see that particularly this one test has 12 of 100 samples false positive. These two and this one have 1 or 2. So this would be then correlating to a specificity of 99 to 98%, which is in some settings acceptable. Of course, 12 in 100 is not acceptable. So there are products that are not ready to use now. They need to be revised. Other products that are already in the market, they can be handled with this knowledge. So knowing that about 1 in 100 tests will be false positive, knowing that a negative result in a person who was previously positive indicates the waning of infectivity. This, of course, could be, as stated in this introductory video, a game changer. So a game changer, especially in the management of diagnostics in resource-poor settings and settings where PCR diagnostics is not available. The absence of infectivity is one of the most important expectations that we have towards diagnostics when we come from a public health perspective. So this is my introductory for the present session. Thank you.
Thank you very much, Christian. I think very powerful examples for the importance, but also impact of science collaboration amongst academics, but also with industry. And that brings me to our second panelist, Thomas Queni, Thomas is actually my neighbor in our offices in Geneva. Currently the Director General of the International Federation of Pharmaceutical Manufacturers and Associations, IFPMA, and has a long career in pharmaceutical research. Thomas, we're very happy to have you with us. What's your perspective on this pandemic?
Thank you very much, Katharina. And as you can clearly see from our screenshots, we are both not on the biocampus in Geneva. Simple reason is that I ordered home office again because Geneva has about 6 times the infection rates of Basel. And I would be interested to learn from Professor Drosten, oh my God, what should the Swiss learn from Germany? Because basically you would expect the healthcare systems are pretty much the same. But when I was watching our foreign minister, who is a medical doctor, why didn't you have enough tests? Why is it so complicated that you need to have 2 3-hour queues to have your test, which certainly would frighten me off. But I think this is a very timely discussion, because when we look back over the last 8 months, we can draw some early conclusions, what worked well, what didn't work well. And we can also draw some, I think, preliminary conclusions on how can we be better prepared for the next pandemic. From an industry point of view, I think I'm glad to say this industry, which is not known for being charitable, but it is really a for-profit industry, has responded to the pandemic, I think, as society would have hoped, because a deep sense of responsibility, because although you have a unique collaboration and openness involving academic research, international health organizations, national regulatory, and others, basically only big multinational corporations have the unique skill set and capacity of scaling up tests, treatments, and vaccines. And in the industrialized world, you probably have not more than a handful of vaccine manufacturers able to manufacture hundreds of millions of doses. And I will talk about that. Early on in the pandemic, the industry, the IFPMA manufacturers have committed to sharing their know-how, their experience, to work together, to collaborate with each other, but also with the society at large. And when you look at that time, when we published these commitments, which was back in mid-March, I've had quite a number of reactions, walk the talk. We would like to see whether you really mean it with opening compound libraries, with sharing manufacturing capacity. I think 8 months later, we see it happened. And one of the reasons is that there was this deep sense of responsibility that the industry has the unique skill set to help us. As a result, 8 months later, we have almost 1,000 clinical trials, more than 300 for treatments. We have 200 vaccine candidates. We have 12 of them in late-stage clinical development. But also we rediscovered that pharma research is high risk, is messy, is bumpy. And some of the early hopes, I think we have had a president of a country saying chloroquine, hydroxychloroquine, that's the magic bullet. Not quite. I recall that in one of our earliest global media briefings, industry leaders collectively said, we really have to approach this with rigorous scientific standards, use randomized controlled clinical trials, use placebo-controlled trials. And as a result, for example, one did find out that chloroquine, hydroxychloroquine, doesn't really work. Actually, it does probably more harm than good. We also saw that anti-inflammatories didn't quite fulfill, at least as monotherapy, the hopes one had. Some of them are still tested in combination, which means you couldn't accuse the company for want of trying, but one has seen that dexamethasone obviously has an impact on mortality rates. One has seen that remdesivir, notwithstanding the recent Solidarity trial results, has proven in the gold standard randomized trial that it does cut the hospital duration. And we have also seen that clinicians have learned to understand how to treat COVID-19 patients better, the right timely use of oxygen, the use of anticoagulants and others. And I've recently heard from Jeremy Farrar that mortality, fatality rates have gone down in Europe by about half. What is interesting also, what we learned, and I think that's promising for future pandemics, we have seen translational research adapted and used. For example, if the mRNA vaccines work, and I think we have reason to hope that they will work, certainly I keep my fingers crossed, we for the first time would be closer to having an ever-warm vaccine facility, because in contrast to classic vaccine technology, they are more agile, versatile, the scalability is much better. Therefore, that could potentially be extremely interesting in terms of future pandemic preparedness. The same when we look at the monoclonal antibodies. Now they are complex, they are very difficult to scale up, they're complex manufacturing processes, and they most likely will remain fairly costly. But on the other hand, within 7 months of isolating antibodies from recovering patients, you have seen proof of concept. And again, if you do look at the bioreactors needed, you could have the scalability and the versatility, which could potentially be interesting for future pandemics. In terms of the second remark, which I'd like to make, is industry did not just have a deep sense of responsibility in terms of bringing its science, it's an engineering skill set to the table, but also this in a pandemic is not business as usual. It's business not as usual. Therefore, I've never seen industry leaders so conscious that they not only need to apply science, they also need to commit to available, accessible, affordable, which means this is not the time for price hikes. This is not the time for making tons of profit if you succeed. Now, as a founding partner of the Act A partnership, we see each other every Thursday evening at the principals meeting. We are fully committed to the principle of equitable and affordable access. But also, when I look at the COVAX facility, that's the one I'm most involved, you do have a commitment of bringing 2 billion doses to the world by the end of 2021, at least half of which should go to developing countries. That will not be sufficient, and it will not be able to fulfill the goal of no one left behind already next year. But when I compare that to the H1N1 situation, where basically all the antivirals, all the vaccines were used up and bought by the rich countries, and we have seen some examples like this again this time. I think it's a huge progress on an unprecedented scale. What I also see in terms of the company's commitment to partnering, we have seen examples, for example, of Eli Lilly signing a contract with the BMGF for using a bioreactor capacity of Fuji in Denmark. We have seen the same on the monoclonal antibodies between Regeneron and Roche, Lilly and Amgen. And we have seen Gilead signing contracts to supply remdesivir in 127 countries using their network of collaboration with Indian generic companies. Therefore, companies have really walked the talk and make sure that they are seen as not just looking after who pays most, who has most money, but really committed to this equitable and the solidarity. Now, I want to briefly respond and address 2 areas of concern. One is, and I'm on a panel tomorrow morning on access, the role of IP. Now, I deeply believe that IP here has been an enabler. Without a strong innovation ecosystem where you have competitive research, strong IP, reward for success, the industry would not have been able to respond from a position of strength, but it was used here for sharing, for collaboration. Therefore, I do believe that IP has been an enabler, but I also believe that in terms of future pandemic preparedness, we need to think about public-private partnerships and how can we make them even better and more efficient in working. The second concern which I've heard is cutting corners. You know, the speed with which, for example, early this year, some people trumped hydroxychloroquine as the miracle drug. The concern about vaccine development. I must say I was really pleased how fast industry leaders responded in terms of committed to, we want to move as fast as possible, but as slow as necessary. And that does not allow to cut corners, have called out to, for example, the FDA, have subscribed to transparency, good and bad results. We have last week just signed up as IFPMA to the EMA new transparency principles, which go way beyond what we have normal. Because if you want to address concerns from people who are anxious about vaccines, you really need to do more than just what's normally required. I think one of the examples which we have also seen is the unique nature of partnerships. We have benefited, CEPI fortunately already existed in 2017. We have seen the ability of Gavi, but we have also seen the importance of, for example, partnering with the clinical trials. I'm sitting on the COVAX coordination meeting with my colleagues from the developing country vaccine manufacturing networks. And I've had people from WHO telling me without the private sector, without industry, there would be no ACT accelerator. I said I would have T-shirts printed for that to remind my friends from WHO that they shouldn't forget that in the future. In conclusion, I'd like to address very briefly, how can we be better prepared for future pandemics? I think we really need to work on health system resilience. When you look at PPEs, masks, tests, oh my God, many of the best organized governments, including NHS in the UK, including Italy, but also including my own country, were struggling, communicating that masks are of no use simply because they didn't have enough, and struggling ever since then to convince people that actually masks do have a protective impact. I think we also need to understand that vaccines and treatments can't just develop pushing the button. Normally, vaccine development takes 10 to 15 years. The fastest vaccine ever developed was Ebola, 4 years. Here we talk about 12 to 18 months. I've been consistent since March this year. I do not expect mass immunization to start before late spring, summer next year. And whatever I read in the media, I still believe that you need a lot of things working together, and normally things are not working that smoothly when it comes to development. Therefore, that's crucially important. But I think overall, you cannot accuse the pharma industry for not trying. I think the industry has really shown its critical importance of partnering. I do believe that after the pandemic, our business model has shown its value. But I do believe that we need to sit down with others, such as my fellow panelists, to talk about what kind of institutional collaboration do we need to avoid the nasty surprise factor we had here with COVID-19. Thank you.
Thank you so much, Thomas, for also tackling questions head on that I'm sure would have otherwise come through the chat. Excellent. So let's now move on to Jay Iyer, who leads the Access to Medicine Foundation as Executive Director. Jay shares my passion for equitable access, for leaving no one behind, but also makes the point that COVID-19 is not the only disease to care about, and that the disruption of other core health services is something that we absolutely have to avoid, and that we have to focus, across diseases. Jay, tell us a bit more about your perspective on this pandemic and what we should do to drive equitable access even better.
Great. Thank you, everyone, for inviting me to this session. I lead the Access to Medicine Foundation. What we've been doing is for 15 years, we've been evaluating the pharmaceutical industry on how the industry has been addressing global health needs. Do their research and development pipelines match set priorities across the world? Do they address affordability? How do they manage intellectual property? And do they actually address access needs in resource-limited settings to the level and the scale that is needed, as 2 billion people still do not have access to essential medicines? Now, we're best known for our work in the Access to Medicine Index, which many of you know is a ranking of the biggest 20 pharmaceutical companies. We've also been doing some work in antimicrobial resistance. And it's very similar to the READY score program that actually Tom leads from Resolve, where they've been looking at countries and evaluating countries in terms of their ability for pandemic preparedness. Here, what we do is we measure what companies are doing, where they're making progress. We try to create that political will and influence in order for us to make sure that the response is fast and responsible and ethical. And we provide technical support in the sense of sharing best practices, gluing people together so that they also understand how to solve specific problems. And while many of us know our work in terms of it's a ranking, it's meant to put companies against each other, it's not really that the case. Companies actually get the bulk of their scores from collaborative activities, and the more they collaborate, the better they do in our work itself. Now, I thought I could speak today about a few key things that we've learned from the pandemic, speaking on behalf of the Access Medicine Foundation, but also speaking as a vaccinologist that I used to be before I joined the foundation. And also I had the privilege of being in Singapore during the whole SARS epidemic and working in Sub-Saharan Africa in the times of all the many other pandemics that we had in the time. So firstly, I think I wanted to point out that priority setting really does matter. When multiple stakeholders come together to decide where are the key areas that we as a society must invest in, where do we need industry, where do we need governments to invest in, pointing out what are the emerging infectious diseases, investing in CEPI, investing in Gavi, matters constantly, and this is what I think has led to some of the progress that we've brought here today. That priority setting, which a lot of the pharmaceutical industry has also responded to, as Thomas already pointed out just now, has also led some companies in being faster in terms of their agility to respond to this pandemic and other global health concerns that we're actually looking at. As we know, the next pandemic could be an emerging infectious disease that's caused by drug-resistant bacteria. So we do need to realize that there's many things that we need to watch out for, and priority setting helps a lot in that. Second area is that we have a stronger appreciation that as a society, we need the pharmaceutical industry, and we need the pharmaceutical industry to innovate, to act, to solve a lot of the gaps itself. Over the last few years, we've seen many companies actually leaving the infectious disease space. And while some of them are able to make that significant step back into a space when we need, AstraZeneca, for example, and Roche, because they kept on in certain parts of their business in maintaining the technical platforms that need to be in place and the expertise in-house. I think we've seen many companies seriously struggle to respond to this particular pandemic in terms of what IP do we actually have that we can actually bring forward into this, since we've left it many years ago. So there's an increasing awareness that we cannot afford to have so many of pharmaceutical companies leave this space, as pandemics are going to be in front of us and in the future also. And that recognition, I think, is an important aspect of it. Thirdly, the pharmaceutical industry is not the only industry that we need to look at here. Big generics have played an important role in stepping up when it came to taking on the licenses for remdesivir and providing some of the supplies alongside Big Pharma when it comes to dexamethasone. Right now, we are also working, as Thomas also has pointed out, with vaccine manufacturers worldwide, as they form the bulk of the manufacturing capacity to kind of bridge that gap that we need and make sure countries are actually ready to help in that supply that we need to match the demand. An area that we've actually been working on recently is with medical oxygen companies. As many of you might already appreciate, medical oxygen has been listed as an essential medicine by the WHO. But that's perhaps in name only. Many countries have not actually put medical oxygen as priority in their national guidelines. And in terms of use, there's been serious shortages in medical oxygen in a long list of countries, which I will not repeat, even recently, India, South Africa. I mean, it's a very, very long list that we looked at. So what we've done in the past few weeks is we try to use our expertise in leveraging the engagement that we have with the industry, medical oxygen producers, innovators around medical oxygen, in trying to bring them forward. And we listed out 10 key areas, including things like identifying where the oxygen gaps are, bringing global health agencies to work with medical oxygen producers, bringing some of the pharmaceutical companies also to work in terms of what are the options that are available, financing the oxygen workforce, in looking at how donors work with local financing and in bridging that particular gap itself. When we think of the industry, there's also companies that supply vials, needles, and many different components that are necessary when we're talking about a vaccine. And I think we need to pay particular attention to the industry that needs to continue their commitment for other areas where we've already made so much progress that we can't afford to let that progress be tackled by this virus. The next thing I think that we've also learned is that more and more we need to leverage different actors in getting involved in this collaboration. We've had the ability for the last few years in building a group of like-minded investors, investment firms that have come together because they've prioritized environment, social, and governance, and prioritized social responsibility in working with us, in engaging with the industry in access to medicine issues, recognizing that sometimes it is a long-term impact that we're looking at for. These 100 investors have now quite collectively done a lot of different things. Some of you may have noticed companies like Achmea, the Interfaith Center for Corporate Responsibility, writing to CEOs of companies and congratulating them on the steps that they have made and pushing for ideas in terms of how can we actually do more and work faster in order to tackle this pandemic. And recently there's an op-ed in Stat News where a couple of investors and ourselves have worked together to support that global collaboration and solidarity, calling out for more of that, which I think is unprecedented. We've never seen something like that. And for investors, the COVID pandemic is a new awakening of sorts. Many have lost also money and sums of money across many different areas. So it doesn't matter what the reason is, they are here. And I think it's something that we need to leverage for the next few years itself. The next thing is, in any response for a global pandemic, we need to make sure that we put the most vulnerable populations front and center in this. And we're able to do that for this pandemic because of the investments we've made in Gavi and because we know how to work with each other in the ACTA platform. Many of us know each other because we've been working towards global equity in some shape and form. But putting the most vulnerable people in front and center means a lot more than that, and just a random collaborations we need to really look at issues in the past few months that we've been facing in terms of gender equity, race equity. The issue of poverty is a real one. And how do we make sure that we are enabling that financing to be bridging that gap when you think about the people who are always left behind in terms of the first, second, or third response. And this is where I think any level of nationalism has really been counterproductive to the efforts that we've all made in trying to make sure the most vulnerable are in the front and center in this discussion itself. In our discussions with various different country leaders, many of them are struggling to understand whether a vaccine is actually going to reach them, and are struggling with how can we ensure that infection control, how can we ensure that the level of diagnostics that are in place and support systems to make sure the hospitals are not overcrowded are really actually going to be made available while waiting for a vaccine, while waiting for medicines to reach. And in some countries, we have, unfortunately, a system where groups of countries are not producing countries. They're used to importing it in and really struggling with this pandemic more than what we can even realize. The next one I think I wanted to point out, and almost my second last point, is this pandemic has brought forward a lot of chronic issues to light. the healthcare system, as Thomas already pointed out, and Katharina, you pointed out also, the fragility of it. How do we ensure that there's adequate financing, and what does resilience truly mean? What can we prioritize when we are running out of options and we need to move relatively fast? But in terms of my experience with the pharmaceutical industry, there are chronic issues in terms of the agility of the pharmaceutical industry in being able to respond to this crisis and future crises. So there are going to be issues that we'll have to face as we learn from this pandemic about what does the future look like, not only for pandemics, but also in terms of all disease areas, in terms of better management of intellectual property, better use of pricing and affordability standards. The next pandemic may disproportionately affect people in low and middle income countries more than it affects the whole world. We don't know that, right? So, but if you look at the priorities that have been set so far, a bulk of them are those that actually affect populations disproportionately in that sense. So I think just in conclusion, I wanted to point out that these kind of chronic issues would be something that we should solve, and we have to think about the ideas. And that's why sharing of good practice, sharing of best practices, understanding what's working, what's not working, having the humility to actually realize that we can learn from each other if we kind of get together and talk about what truly has not worked alongside what has worked, I think is an important aspect to make sure that we fix those chronic issues that plague systems and the industry's relationship with the system, let's put it very simply. I think lastly, I think the success of this pandemic and any global health challenge needs to be based in terms of local availability of health care. And care includes products and services itself. And I hope that by next year, we will have some idea of what that local availability would look like. To some degree, not only for in terms of infection control, but I think that as humans, we're very good in making sure that we respond very quickly in terms of systems, especially when it comes to pandemics, but not necessarily very wise in terms of preparing for what's in the future is going to hit us. So I wanted to stop there and say that these are my 7 reflections of what this pandemic has taught us. And in January, we'll be publishing the next Access to Medicine Index. And there we will look at how individual companies, the collaborations have responded in terms of COVID. How ready are we for future pandemics? What is the pace at which other areas in the 76 other diseases that is covered by the index, have they been taking a beating, or how have they been brought forward in a different way? So I think I'll close there. And right.
Thank you, Jay. We all look forward to your report, and thanks for raising these important concerns. Finally, I'm very honored to have with us Tom Frieden. I think, again, you need no introduction, but Tom is the former director of the US CDC and now leads Resolve to Save Lives, an organization that sets out to save millions and make the world safer from epidemics. I think amongst all of us here on the panel, you're the only one who dedicated and devoted your entire career to better pandemic preparedness, Tom. So what have you learned through COVID-19, and how has your thinking evolved during this crisis?
Thank you so much. And it's great to be with the panel, and really appreciated Christian's comments about testing. And I think one of the components of pandemic response is getting testing right, and also getting it right within the context of an overarching strategy. One of the biggest challenges I see, at least in the US, where our response is so poor, so failed because of a failure of national leadership, that people are always looking for the one thing that's going to make COVID go away, whether it's a travel ban or staying home or masks or testing or even a vaccine. And no one thing is going to make it go away. We need a comprehensive adaptive response based on science, learning new things. And Katharina, it's just so nice to see the work that you're doing with FIND get more appreciation and recognition. I've always said that the laboratories tend to be the poor relation of the health system, and we need to change that. And for IFPMA, we recognize the extreme importance of addressing access, the confidence, and the quality of pharmaceutical products. And Jay, it's great to hear about the work you're doing, and I'd love to hear more about the medical oxygen work. This is a particularly important area. We look around the world at the lack of medical oxygen, lack of competent primary care, lack of running water in health facilities in many countries of Africa and parts of Asia. So let me actually just share screen and think a little bit about where we are now and what comes next. So first off, we have to recognize that COVID is a long-term threat to public health, and the pandemic is nowhere near over. I wrote these slides a month or two ago before the big resurgence in Europe, but it's very clear. This is the most disruptive infectious disease threat the world has faced in a century. I don't say it's the deadliest. Remember, HIV has killed 30 million people. COVID will not kill 30 million people, but the disruption that COVID causes could kill many millions, and I'll come back to that in a minute. The risk of explosive spread is not going to end when we have a vaccine. And what we see all over the world is that places guided by and that fully support public health have less disease, less death, and less economic devastation. Victoria, Australia just celebrated their first 24 hours with no cases. It is possible to crush the curve here. But what you need is a comprehensive response to reduce spread, stop cases and clusters, protect ongoing healthcare, and use data to drive progress. And to spend just a minute on each of those four, I think of it kind of as to use a kind of a Marshall analogy, a 1-2 punch. What you need to do is drive it down with the general measures, the hammer as it's been called. But that can include not just closures, but the 3 W's: wear a mask, watch your distance, wash your hands. And we can be more strategic about the kind of circuit breaker approaches. Lockdown is a bad word, but we don't have an alternative really. It's good to go outside, and very, very little spread out of doors. And many indoor locations can be safely managed through the pandemic with safety features and masking and others. Others are much harder. Bars in particular, restaurants also, big difficulty. And then stopping cases and clusters. And we talk about the box it in strategy. Test strategically, isolate promptly, contact trace completely, and quarantine with a supportive way. And that basic approach works if places stick with it. But if you have too many cases to do that, then you need a broader lockdown. When you get cases down to a low level, unless you do that well, you're going to risk a more rapid resurgence. So there is a clear strategy that works here. Data is the lifeblood of public health. Good data analyzed and applied properly drive decision-making. Analysis can facilitate program improvements by providing real-time feedback on what interventions are working and where they need to be improved. And Christian, I was just thinking during your talk today, there's so much we don't know. For example, can we correlate the point at which infection is transmitted in the illness with the severity of illness? Can we suggest that there's an inoculum effect? These are studies that can be done through meticulous epidemiological studies. Data can also help build political and public support, especially for controversial interventions such as closures, and can provide accountability for program implementation, quality, and progress. I think back to the mask issue. If you go back to January, February, even March, few people in the West believed that masks would be very important. So it wasn't merely that there weren't enough. I think some of the discussion since is just, oh, because they weren't enough, we weren't recommending. Well, it's certainly the case because there weren't enough N95s. We weren't recommending N95s for healthcare workers, although many of us said all along, we should be saying healthcare workers should use N95s. If there aren't N95s, then use this. If not, then use that. But more to the point, as we learned the surprising virology of COVID, remember, with SARS and MERS, as with tuberculosis, the sicker you are, the higher your viral load, the more infectious you are. So the most infectious SARS patients were the intubated patients. And when we had an example from Singapore early on of an intubated patient undiagnosed with SARS with 41 healthcare workers wearing only surgical masks and none of them infected, we said, well, wow, it's not that infectious. But we missed it. What we missed was it's really infectious right around the onset of symptoms. And it's not very infectious at all 7 or 10 days later. And that's really what led to the recognition of the extreme importance of masks. And the fact in the US that we weren't talking with people daily, that CDC was silenced for telling the truth, meant that people really couldn't walk that path of discovery together and weren't on the same page. Now, the world remains woefully underprepared for epidemics. Public health systems have suffered from years of underfunding. And as you say, Katarina, we've been discussing this for years. But now is the time really to make a difference. We need a creative solution to strengthen and sustain core capabilities of the public health system: prevention, detection, and response. We can't afford another multi-trillion-dollar pandemic that kills millions of people avoidably, but we can afford the global health security to prevent it. And Tony Fauci said, never again should we be as unprepared for something as catastrophic as what we're going through now. Health threats can either unite or divide the world. And I remember that famous quotation of Albert Einstein: nationalism is an infantile disease. It is the measles of mankind. The choice really is ours. Health has been a bridge for peace in smallpox eradication when the US and the then Soviet Union collaborated, in childhood vaccination where wars have been stopped to vaccinate children, in the global elimination of lead in gasoline, and more. Vaccine nationalism will backfire. The only way to control this virus and lead to global recovery is a global collaboration and coordination. Global commitment to strengthening early warning, rapid response, and effective prevention is also crucially important. It can save millions of lives and trillions of dollars. And I would say that it is literally, and there's one thing I'd like you to take from my remarks today, it is literally now or never. We have a global pandemic that's cost, by the latest estimate, $16 trillion. A year ago, we were struggling to say, is there any way we could get $5, maybe $10 billion a year for a decade to really drastically improve preparedness? And it's still unclear if we'll be able to do that. People are willing to throw money at a crisis, but we are inevitably seeing cycles of panic and neglect, and we've got to address the opportunity now. I want to talk about the World Health Organization for a moment, because WHO is essential and necessary, and it has made mistakes. In fact, I would say there is not an organization in the world that has not made mistakes when it comes to COVID. But WHO is essential for data, for guidance, and for country support. WHO accurately gave China credit for extraordinary control measures starting in late January, but it was silent about serious problems with China's early response. WHO provided early warnings in January that weren't heeded, and it has generally performed well in the pandemic. It's a United Nations entity, and that means it works through consensus, and that may need to change in the context of emergency notification and response. The world needs WHO, and it needs it to be even stronger. But the World Health Organization is not sufficient. At $1 to $5 per person per year of new funds for 10 or more years, we're talking about $5 to $50 billion a year for at least a decade to close life-threatening gaps in detection, response, and prevention. And if we really step back and we think, what have been the great successes and the limitations of our global programs? We see tremendous progress fighting HIV, TB, malaria, some progress on drug-resistant bacteria around the world, enormous progress on vaccine-preventable diseases. But there's a crucial triad that's needed. First is money, financial support. Second is robust, intensive technical support, not outside experts or not only outside experts, but building national capacity so that countries all around the world have robust epidemiology, clinical trial, robust research, and robust control measures based on addressing day in and day out deadly problems that they faced. And not only financial and technical, but also management, operational support. And I'd like to recall what Dr. Bill Foege, who really led many of the global smallpox eradication efforts in both Nigeria and India, establishing the ring vaccination strategy. When he was asked what next after the eradication of smallpox, he said, the eradication of bad management. And we're still a long way from that, but we are at Resolve to Save Lives committed, completely committed to doing whatever we can to partner with organizations and governments around the world so that we can have truly a much safer, more robust, more productive world. Thanks so much.
Thank you very much, Tom. It's literally now or never. I think we all agree. So, let me ask in our question and answer session, let me start right away with you. Now or never. So what do we concretely together do now to change this? We're in the middle of as you said, the second wave in many countries. And yet we also should already put systems in place that help us act, better next time. So what is the next step?
Right. So there's a perspective that we should kind of just deal with COVID and not do anything else. I think that would be a big mistake. We need to not just address COVID, but also address many life-threatening gaps in preparedness that have been identified in countries around the world. And that means finding the funding and the political will for global health security. This is a global responsibility. Diseases don't know borders, and we need to work together. I think we're going to have to figure out ways to fund it. We're going to have to also figure out how we can better support primary care around the world. Primary care is the poor relation all over the world. And so we have huge gaps, and the risk is that not only will there be hundreds of thousands or millions of preventable deaths because of COVID, but that we will come out of this still woefully underprepared. It's inevitable that there's going to be another pandemic. What's not inevitable is that the world will be so underprepared still. And we have to strike while the iron is hot, really. We have to ensure that with this kind of global attention and recognition of what infectious diseases can do, that the kind of both financial commitment and political commitment to working together, recognizing that we're really united by our fight against the virus and the microbial world. And if we can do that with real global collaboration, we'll be massively better off as individuals, as communities, as countries. We have to build that momentum and get past both strengthening WHO and creating robust systems to strengthen public health and to hold countries accountable for improving primary care.
Absolutely. Christian, I'm sure you also have a perspective on this. Both of you and Tom also talked about the power of data. So from a science perspective, what's next for you and what can serve both purposes, the COVID-19 response as well as better preparedness going forward? There was also a question from the audience on what lessons are applicable to the next possibly bacterial outbreak that we may face. So what if this holds true beyond viruses?
Well, I mean, the data discussion, of course, is complex. Data sharing, data availability, data exploitation. I mean, there is a significant improvement with data sharing when you look at sequence data. However, sequence data are not that useful during this present pandemic. We have to admit to that because the viruses are completely mixed. They are distributed across the globe. We are now seeing, actually for the first time in the last few weeks, we are seeing the emergence of some virus variants that we don't understand, where we still don't know whether some changes in the genome would have a functional correlate. But what we expect in terms of the virus evolving would be at some point the occurrence of slightly deleterious mutations that are then not eliminated. So while there is still very intense circulation of viruses where you have wild-type viruses competing and usually outcompeting slightly deleterious variants, we know from the fate of other respiratory viruses after their emergence that deleterious variants can transmit and can sometimes be transmitted with equal efficiency as compared to the more pathogenic wild-type viruses, because deleterious variants are often slightly attenuated in terms of pathogenicity. And then this, on the long term, seems to result in an advantage for the virus. So that's how we conceive how attenuated viruses come up. But we don't conceive this to happen for the present virus during the present pandemic. While we are now seeing first variants popping up in the bigger and bigger cloud of shared information, of shared sequences internationally. But there is still no reason to really believe that there is a functional change. We know there is one functional change that occurred very early on, also known because of data sharing, because of the speed, how this mutation could be tracked in its way across the globe, which is the D614G mutation in the spike protein. Also there, we have an explanation. This is a mutation that increased transmissibility and left pathogenicity unmodified. Yeah, so that's an example for data sharing, but it's, as I said, it's not very informative, this sequence information. The other thing is, if you look at a page called Our World in Data, it's impressive what they provide in terms of information. So we can retrieve the rate of testing per country. We can retrieve the rate of, let's say, fatalities or new cases almost on an online real-time basis. So this is really remarkable and it's new. This is very encouraging, I would say. Obviously, the precision of these data sources needs to be even developed even further. But at some point, this becomes a matter of funding and a matter of collaboration with, say, more national data hubs. So that's all very encouraging. In terms of, well, prediction, let's say, the oversight of over viruses, what we can do to prevent the next pandemic, to recognize it early on. So the best guess would be looking at virus origins, virus reservoirs, to focus on livestock species, or on, let's say, in a broader sense, on animal species that are exploited by humans, that are kept in artificial husbandry, and to really switch from just some research studies into a real surveillance. And of course, the concept to do surveillance on wildlife is maybe taking it a bit too far. This is hardly doable. The complexities that you face will always throw you back onto research scenarios, while livestock surveillance, or let's say used animal surveillance, is a goal that can be achieved even in countries of the global south. And I think this is an important goal, including for the surveillance of bacterial pathogens, by the way, because this is where most of antibiotic resistance genes come from and are then evolved into human pathogenic bacteria.
Absolutely, yeah. So Thomas, let me maybe take it from there. I know you're also very interested in both in the One Health approach, but let me ask you, both you and Jay have touched upon you know, the global public good aspects. And Jay talked very much about new business models, and you talked about the value of traditional pharma business models. How do you think, from your perspective, you know, has this COVID-19 crisis changed the approach to pharma development, spurring companies towards a more genuine or a genuine willingness to approach development as a global public good approach?
Now, Katharina, as you know, I'm not a medical doctor, I'm an economist, and therefore I have to admit I don't like the term of global public good in this context, for a simple reason. There are clear definitions of what is a public good, and it is the non-excludable and non-arrival risk. If I get the COVID-19 vaccine before you get it, I'm better off than you are. And you know, that's the situation as we will have in 2021, where you have to make allocation decision. Having said that, I think we all strive for the same. I think we all understand, and there I firmly agree with Tom Frieden on we do need a strong WHO. We need also to look into its strengths and weaknesses. For example, one of my conclusions is we were lucky to have quite a number of specialized organizations which have grown up over the last 20 years in Geneva, such as Global Fund, such as CEPI, such as Gavi, not, let's say, struck by the same kind of bureaucratic and political obstacles that you inevitably will always have in WHO, and we certainly should not give that up. In operational respects, I believe that UNICEF, CEPI, Gavi, FIND, and others are much more agile and flexible. But I think what we have to really aim for is, at the end of the day, no one should be left behind. In order for that to happen, you need to have a solidarity between the rich countries and the poor. You need to overcome this vaccine nationalism. Now, I hesitate to, let's say, criticize the US as you know, the worst in that respect, because let's face it, we wouldn't be with vaccine development if it hadn't been without BARDA. BARDA was really the first one to put significant funds into risk sharing, into at-risk development, clinical trials, and scaling up. And all of us, to some extent, will be free riders of what the US taxpayer funded. But we need to make sure that this is also accessible and available in developing countries. I think there we need to work together. Initially, when we started in COVAX, everybody was sort of having the idealistic dream that COVAX would be the facility for the world. This did not happen and probably was never realistic, and not just because of Donald Trump. You don't have much difference in terms of China or India or Russia or the European Union. Even now, we still have some, let's say, strange confusion about how exactly will the European Union support the COVAX facility. And I see how you struggle to raise the money for the diagnostics pillar. When you look at the staggering amounts of economic impact of COVID-19 per month, when you look at the quantitative easing on the one hand, and let's say the peanuts you get for diagnostics, let's say we haven't been able to get out of the overseas development assistance basket or bucket. And I hope that we will be able to do so. We really need to have an understanding of the not just public health, but the macroeconomic impact on the world. And that requires solidarity.
Totally agree. And the case for investment should be so clear in terms of return. And yet we have huge financing gaps in ACTA, for example. Jay, what is your opinion? Are we doing enough to ensure that the new innovations we already have or will have going forward reach vulnerable populations? And are the existing mechanisms from your perspective suitable?
It's a tough question, I must say, to answer. I think that one of the things that we've noticed is that this pandemic has put a lot of pressure, especially in vulnerable populations, least developed countries. It's really difficult. A lot of the companies, even that Thomas represents, have been struggling to keep their commitments in these countries itself. So it is difficult, especially when you think about all the progress that we've made in HIV, malaria, TB, a range of areas in achieving the level of universal health coverage that we actually need. So, and a lot of that has been banking on the fact that companies are able to respond, governments are able to respond, also because they've tried it before in another area, right? So there's already been a system that has been created from neglected tropical diseases for IP sharing. There's already been a system of relationships that have been created for vaccine development and deployment via Gavi and CEPI in that sense. So, and we were lucky early on in this pandemic also to discover that a relatively low cost drug like dexamethasone that is relatively widely available was available in that sense. So you see again that you need big pharma, but you also need some of the big generics to step in, and the ones that stepped in and moved at that faster speed were the ones who also had that experience from before. So I think there has been some chronic issues in the pandemic that we need to keep an eye out for, such as I think the nationalism. One of the things that it has really affected in terms of some of the trade sanctions that have been there from the border closures is active ingredients, the cost of active ingredients, the number of companies that even make some of these active ingredients for drugs has been really jeopardized and put under quite a lot of pressure. So much so that we've heard reports that we've been looking at in terms of patients paying 500 times more because of import taxes, and on top of that, API prices going up, skyrocketing. Even things like drugs like remdesivir need to be reconstituted, prior to administration, and that reconstitution substance costs money and a significant amount. So we've been monitoring also some of the prices and the situation in terms of how the different companies working to solve some of these problems. Are there examples that we can use that we can sort of amplify and propagate? I think one of the things to watch out for is that we don't actually have a system to solve the ability of how medicines and vaccines reach patients all over the world in an equal and timely enough in an equal manner. And that has led to a lot of fears in terms of which countries are going to be left behind, which populations are going to be left behind. And those fears are legitimate, because I think in this pandemic has chosen to infect people all over the world relatively equally in that sense. And doesn't necessarily care about borders, but the next pandemic and a lot of previous pandemics that we've had so far have been disproportionately affecting the poor. And I think a lot of the issues on intellectual property are real, as evidenced by the waiver that was put on the table and voted against. And many countries have been struggling and looking at, okay, can we actually enforce legislation to ensure that we have the ability to put compulsory licensing on the table if a vaccine is not reaching us when it does reach populations in another parts of the world. So that level of equity is something that is a chronic problem that we need to actually solve, and we need to solve that in peacetime or in pandemic time. We just need to solve it as quickly as possible. So when you think of that, the new systems, I don't think that we should think of creating a whole range of unrelated new systems, but we need to look at existing mechanisms. And not many platforms for addressing affordability. There are not many platforms for addressing innovations, new innovations. One thing that we've been pushing for, that I think every single donor out there and every single supporter of innovation out there need to understand, is we're nowhere if we can't develop a key product. But while a product is in development, making sure that all the relationships, all the groundwork that is put in place to ensure rapid registration, affordability, access, supply is brought into place. We loosely call that term access planning, planning for access when a product is in development. That is so critical, and even more critical than ever before. And that's something that can be supported not only by the innovators themselves, but by the people who engage with innovators in that sense. So I think the way that we invest in healthcare, the way that we invest in new innovation, the way we bring back areas where companies have left, and there are very few innovators out there. We assume when things are generic, there's going to be a lot already available. That's not the case. Some things have reached positions where they're just not economically viable, like antibiotics, that we still need to tell when we know a difference between an infection that can be treated with antibiotics versus a viral disease. So I do think that there's quite a few numbers of chronic issues that we do need to pay attention to. Otherwise, we'll never be able to reach the vulnerable populations properly. And even if we do, we can't leave them to be lost in line. That is unacceptable in any circumstance.
Absolutely. Tom, you're more focused this time on the US, but a lot of your work has been also, with countries all over the world. So I have a question from the audience on, how do we measure preparedness? The Global Pandemic Monitoring Board recommended that we do simulations to test the system, to test the strengths of the system. We had a pandemic preparedness index in the past. You have co-led the work of the joint external evaluations that now also sort of in some ways have been criticized. So going forward, how do we measure? How do we ensure accountability? If you and maybe also Christian could briefly comment on that.
That's a great question. First off, I think there's a misconception that the joint external evaluation didn't correlate with preparedness. Actually, it correlates quite well with one exception, that governments that didn't listen to their public health system didn't benefit from a strong public health system, including in the US. So I think this adds a political dimension to preparedness. I think also it's really important that we use the real world as our drill. There's been, in my view, a little too much theoretical stuff and not enough real world. It drives me a bit crazy when donors or think tanks go into a country in Africa and say, let's do an exercise to see how we would handle an epidemic when there are measles outbreaks happening, yellow fever outbreaks happening. I mean, we have to use reality as our drill. And one of the things that WHO has begun looking at, and I think has a lot of potential, is looking at timeliness. Timeliness is really important. Speed matters a lot. Hours matter, days matter. And what we're seeing, I mean, I'm sitting here in New York City, and the period between March 7th and March 22nd was excruciating, because many of us in public health knew what was going to happen. And we felt like Cassandras, other than kind of immolating ourselves in the middle of the street, there was nothing we could do to get the city to shut down faster. And we knew this was going to be deadly. So I think timeliness is really important to measure. And then we need a way of determining whether there's political will to listen to science. Now, when I worked on tuberculosis for many years, we had a debate about how do you measure political commitment? And the technical people had a very simple measurement. If you go to every health center and they have a copy of the technical guidelines, then you have political commitment, which is interesting. But another group said, if they're spending money, then they're committed politically. So I think we need to look at the funding, staffing, because one of the things that we found about, to tie this into the earlier question of what do we need to do to be better prepared, a lot of the gaps are human resources. Do we have enough public health staff? Are they paid well enough? Are they supported enough? Do they have institutional support, which might be a National Public Health Institute or a public health system? That kind of fundamental question of, does the government actually support public health and primary care? I think that's what we need to look at. And I want to come back to primary care just for a minute, because I've been thinking much more about this in the past few months. In our work at Resolve, we have two broad areas of work. One is epidemic readiness, and the other is cardiovascular health and prevention of heart attacks and strokes. And in the cardiovascular work, we focused on the treatment of high blood pressure, which is the world's leading cause of death. It kills more people every year than all infectious diseases combined. It can be treated by medicines that only have to cost a few dollars a year. It's simple treatment, much simpler than, for example, HIV treatment. It can be done by algorithm. It can be team-based care and task shared, and yet it's not done. It's not done in most of the world. It's not done even in countries that have relatively strong healthcare systems. In the US, not only is it not done particularly well, but it got worse over the past 5 years, despite a major effort to improve it. And I think the lesson I draw from that is that there's a lot of lip service to primary care, but that's exactly what it is. It's lip service. And until primary care has real financing, we're not going to change things. All the exhortation in the world won't make much difference if we're not paying for primary care. Now, that's a different area. Primary care is not public health, but these are two areas that have been really underfunded. And there is some overlap: infection control, running water, information systems, team-based care, a role for nurses. This is all really important, but I think it's really striking the degree to which there are so few countries that have both good primary care systems that are accessible and primary care systems that are delivering high-value health, because you end up really having to structure carefully. So you can basically count on the fingers of one or maybe two hands the countries in the world that have sufficient investment and sufficient value out of their primary healthcare systems. And that's stunning, really stunning. So I think both the public health and the primary care, and what's the common denominator between those two things? You need political will to get you there, because you don't have an alignment of economic interests to get you there. I can talk about hospital sectors in many countries, including the US, huge economic driver and huge political power, far disproportionate to their potential health impact. Mm-hmm. Primary care, not much. So I think really, if we're thinking about what is going to make the most difference in health, it's about primary care and public health, and getting those things invested in a big way. And again, it's literally now or never. This is the time to make a huge difference and demonstrate. And for all the commitment to universal health coverage, what I see as an observer of this is the real risk that primary care is once again the poor, neglected relation.
Absolutely. Time is flying, and we're nearing the end of the session. So while I ask the organizers to upload our summary slide, can I ask each of you, starting with Christian, to tell us, the theme of this conference is about global cooperation, partnership, and each of you have spoken about, the value of partnership in your area. So with the framework in mind, can we show the slide, please? With the framework in mind, what for you, Christian, in sort of one sentence, what's the most important partnership you want to see built between now and next year that would really change our ecosystem?
Well, I don't know whether we really need a game changer. Academic collaboration is in place and is really a bridging partnership. It bridges hemispheres and bridges cultural backgrounds. And well, obviously the collaboration on the academic level, but then also to draw into this collaboration the public health levels on both sides of the collaboration. I guess this is not an innovation, it's not a breakthrough, but better financing for this essential, let's say, tier of collaboration on the working level is absolutely essential.
Absolutely. Science collaboration from academia. Thomas.
Thank you, Katharina. I believe that we really should build on what we now see with the ACT-A partnership, the public-private partnership. I do believe that we should not think that pandemic response is the new normal, but we need to think about how do we transition from the business as usual to better pandemic preparedness, and that does require a partnership before the pandemic, not just when the pandemic, the crisis is there.
Great, absolutely, totally agree. Jay, what is the one point in this framework that you think would make us advance the best?
I mean, the point of every framework is that it has to kind of work together. But since you're asking me for one, I would say that the area where I think we have the most concerns is governance and regulation, where, you know, can we actually get together fast enough and appropriately enough to be able to come up with the creative collaborative solutions to tackle problems, whatever the problem may be, whether it is this pandemic, a new pandemic, or tackling a larger crisis in global health that is alongside and still happening.
Absolutely. Tom?
Money talks. I think we really, really need to make sure that there's funding going into global health security, into finding, stopping, and preventing health threats when and where they first emerge. And this can't be money that's just relabeled from existing money. This needs to be additional funding with strong mechanisms to get it out with accountability, with technical support and operational support, building national capacity. This is the essential thing that has to happen for the world to be better prepared. Otherwise, shame on us. Next pandemic will have the same kind of avoidable economic, social, and health harms.
Great. I think, you know, I couldn't close this better. And as you said, the time to act is now. You know, I would like to close this session by thanking the panel for bringing such different perspectives and such a comprehensive view on how to be better prepared, and the audience for asking a lot of interesting and diverse questions that really enrich this discussion. We've tried to capture on this closing slide a number of key messages from this session, and we'll expand it and share with everyone. But let me just say thank you to everyone, and let's work together to make it happen, to not be in a panic mode and panic response reaction next time around, but actually be better prepared. Thank you.